talk about, after such excellent lectures with Professor Dolans, Kato, and Professor Krish, I have to find some way to do something different. So I will just talk about the bipolar coagulation in aneurysm surgery. It is just some issue. There are many issues in aneurysm surgery, but I will just focus on the bipolar coagulation in aneurysm surgery. As you know that the basic bipolar coagulation system introduced by Dr. Greenwood from Houston. He called this system as a two-point coagulation in 1940. It was a great development after the introducing of monopolar Bowie system by Cushing. So this was very important step, but somehow it was not used commonly. But Professor Mallis perfected this system, and he called this system as a bipolar coagulation. And he used this system in his laboratory. And as you know, some of the colleagues maybe know personally Professor Mallis. He was one of genius person that I ever met, and he developed this system. And it is interesting. He used this system in laboratory, but Professor Yaşargil used bipolar first time in the operating theater. And maybe Professor Yaşargil will mention the detail of this story, because this system was sparkling. So in Zurich, they modified the system and it stopped the sparkling, and Professor Yaşargil used bipolar system and he started to use in 1966 in micro neurosurgical procedure. And as always, Professor Yaşargil mentioned, microneurosurgery is not just using microscope. Without bipolar, neurosurgery could not be exist. So, and not only the dissection, also coagulating and the preserving small perforators, and there are many functions of bipolar that it looks like our fingers that we are using. So what I will share with you today, nothing is special, just what I learned from Professor Yaşargil. I started working with Professor Yaşargil when I was second years of resident. So everything I am doing is just copy of him because I did not have any other teacher when I start my residency. So I am just simulating his surgeries. And it is also something is important. All of the cases that I am going to show you, Professor Yaşargil was in the room. So it was also another stress, of course, but it was more chance than stress because I had more courage when Professor Yaşargil is in the operating theater. These are described by Professor Yaşargil, 1984 in volume 1, and he described step by clipping and the bipolar, using bipolar. And also this picture illustrates that how you can use bipolar coagulation to give a shape for amorphous aneurysms or broad-based aneurysms. So fundus, another trick, middle part, another trick, and neck part, another trick. So this is the first case that I would like to show you. Left is left always in my MRI, just like Professor Yaşargil, because this is the correct orientation to me. So this is left-sided incidental paraclinoid aneurysm. And you can have this angiographic picture and 3D reconstruction. I love this. Pablo Gonzalez is introduced this Osiris 3D reconstruction, and without this reconstruction, I don't perform any surgery. So this is left-sided paraclinoid aneurysm. So I just remove the clinoid And this is left side after Sylvian Fisher opening. I love ICG, as all of you, I'm sure, you're using. I think ICG is the one of the most important development in last decade in neurosurgery. So the right, so left internal carotid, left A1, left M1. And I just put a clip, temporary clip in the proximal carotid, and then distal carotid. Still, I don't know where is anterior choroidal, and I don't know where is posterior communicating. And I find that the aneurysm is softer, so I use bipolar. This is very important. We should not use bipolar in the tip first. We have to use bipolar in the base. And with the small, so this is posterior communicating now. I can see posterior communicating. So I have to put
video, Professor.
Clip.
Yes.
Yes.
But the low quality, because these videos are 4K
okay.
videos. I am sorry. So
video
this
might
is
be
left.
poor quality, but surgeon is good quality. So that's no problem.
Sorry. So this is left side paraclinoid. And can you see video now?
Yes.
Yes.
Yeah, okay. So I put temporary clip the proximal part. The left optic is here. And I put a temporary clip to distal. I don't see anterior choroidal or posterior communicating. I am coagulating the aneurysm to see the base. And of course, I use 0.7 bipolar, not very, tip should not be very small. And the Mallis, this is posterior communicating now. Mallis 20 or 25 setting is, I use it. And I put a temporary clip to PCOM also, because, and then now I coagulate more. The third nerve is here now. And I suck the blood. And now I can see posterior communicating. And you see that posterior communicating totally thrombosed. So the posterior communicating is not working. So I am a little trying to do fast because I don't put temporary clip more than 3 minutes. Why 3 minutes? Because Professor Yaşargil was telling 3 minutes. So I never try to do more than 3 minutes. And coagulate and give a shape to aneurysm. And still there is adherence here in the carotid part. The neck is, I have to prepare the neck of the aneurysm. You see, there is, now I can see the neck here. And so and I put a clip in the base of the aneurysm. And I take out the temporary clip. And anterior choroidal is here. And there is a little bleeding here. And I coagulate more because I have to get the whole base of the aneurysm. And anterior choroidal is here. And there is a little bleeding. I just put a cottonoid. Maybe it will stop automatically, but still I prefer to put a cottonoid and preserve the carotid. And then take out the temporary clip, and you see there is still, you can see now the superior hypophyseal artery. And there is a little piece of aneurysm here, and the carotid is open. And the superior hypophyseal is working, and anterior choroidal is working, and the A1, M1. And I put another clip to this part, small part. And then ICG shows all the vessels are intact, and including superior hypophyseal and anterior choroidal also. Here. You see the anterior choroidal and the superior hypophyseal. Another case, this is a ruptured anterior communicating aneurysm, but also there is a paraclinoid aneurysm and also carotid bifurcation aneurysm in the left side. I normally use the right craniotomy for anterior communicating, but because that there are two more aneurysm here, so I perform left-sided pteronal approach. Again, after clinoidectomy, this is internal carotid, and the aneurysm base is here. And interesting, the aneurysm gets very soft when the anesthesiologist push the compress the carotid in this case. So I was lucky enough that I didn't put the temporary clip also for this. So when anesthesiologist compressed the carotid, aneurysm was almost gone. But there is calcified part of aneurysm. So we should be very careful. The coagulating aneurysm is also dangerous procedure, especially if there are perforators around. We have to separate the perforators, and then we can use this trick. But it gives shape to aneurysm, and then you can have a shape for the clipping the base. As you know, that neck of aneurysm is not exist, almost 95%. There is a generally broad base. So, and then we remove the blood within the aneurysm and then coagulate more, but we cannot take out this calcification. I just cut the tip of the aneurysm, and I have to be sure that aneurysm is not filling. And then I went to the anterior communicating, which one was, this is ruptured. So I put a temporary clip the left side, right side is in front of me. I have to see the aneurysm, but the Höbner is totally adherent to the aneurysm. So I am ready that if the aneurysm is rupturing, and it will rupture now. And I like to see the blood, I feel more comfortable. The one, because this left A1 is more dominant, so I continue to separate the Höbner from aneurysm with bipolar. And it's not easy. At least it was not easy to me. And because if we put a clip without preserving Höbner, you can imagine what may happen. And I still continue, and then I decided to put other side, but still bleeding. It's better. I know the aneurysm. I see the base of aneurysm, and I see the Höbner, so I continue to dissection. Yeah, you see now the better. Yes, now I almost separate. And the coagulation also of the aneurysm is good to control the bleeding also. So this is pilot clip. It's not final clip. There is a calcification also in the base. So I remove the temporary clips. And then some minutes later, I take it out again to see aneurysm better. And to get because this inferior part, Professor Yaşargil always mentioned that there is also a piece of aneurysm there. So the coagulation is very effective there, and to also prepare the aneurysm base. And then going. So this bleeding is not disturbing me because this is in my control. And also I feel better that it's bleeding. So the brain getting more blood. So I put this clip, but still I am not happy. and I change the position, but still I am not happy. And then I take it out and I put a straight clip. And of course, we have to see the tip of the clip, that we should not obstruct the perforators. So this was the second one. And then third one was the most difficult one, because this is the carotid bifurcation aneurysm, and the perforators are just there. And we could not use bipolar so much in this condition. Actually, we don't need, because this aneurysm had a nice base. So we perform the clipping this aneurysm also. And then also we check with the ICG always. You see the whole perforators are open, and the anterior choroidal and the carotid bifurcation and anterior communicating also Hübner is intact, you see. Another case, anterior choroidal aneurysm. I am not going to show anterior choroidal, the right side. Anterior choroidal is clipped, but I would like to show this small bleb that Professor Yaşargil always mentioned. We see this many times. So I put a temporary clip to M1, and I just coagulate around the aneurysm. And then I put a small piece of cottonoid for this maybe future aneurysm. This is another trick. I have to skip, I think, this one, maybe because my time is, yeah, I like to show this one. This is ruptured pericallosal artery aneurysms, but there is also unruptured right-sided middle cerebral small aneurysm. In the same session, I use the same incision, 2 craniotomy. In same session, I explore this middle cerebral bifurcation aneurysm, which almost looks like a fusiform aneurysm. So this is a bifurcation. This is inferior trunk. These two are superior trunk. As you know that there is no trifurcation. These are also, this is bifurcation. But you see all this bifurcation region is thick and not easy to clip. And again, ICG, I perform, and then I put a temporary clip to M1. And start to coagulate and give a shape to, for clipping. Don't start from the tip of the aneurysm, just around. And starting, you see this part is also thick. And start with low power, 20 Mallis unit is suitable. And water is very important because the bipolar should not be stick. And the inferior part is very critical. Of course, we have to see the perforators and not coagulate immediately and shrink immediately, just stepwise, slowly. I am planning to put a clip in this part, so I am preparing this part for clipping. And then, because that it takes 3 minutes almost, I take out the temporary clip. So I take out and then wait for 5 minutes, and then also to see how it's going on. So I can do more. I have to do more. So I put temporary clip again. But it looks like there is some piece for clipping. But if you coagulate too much, you cannot find any place to put a clip. So we have to be careful. As I told you, the bipolar should not be very, the tip should not be very fine and should not be very thick. 0.7 is generally suitable for me. And then, of course, I cannot put a clip too much down, otherwise the other M2 segments can be blocked. And now, looks not so bad. This is right inferior trunk. And then ICG shows. And of course, I put a cottonoid around this aneurysm, and we are following this case. And maybe I have to skip this one. Yeah, M1 aneurysm may be more interesting, because in right-sided M1 aneurysm, and because there are always perforators just in the base of the aneurysm, there are perforators always in the M1 aneurysm. So M1 aneurysms are more difficult than bifurcation aneurysms. So we check with the ICG, we have to see the whole anatomy, and then start again to temporary clip and start coagulating slowly, because this part is totally adherent to the this M2 segment. So I have to separate it. And the bipolar coagulating is the helping for separation. Again, I have to work in the surrounding region, and there is aneurysm underneath, and there is perforator underneath. So I have to be careful in that part. And just to see below, this is most important part, because I will see the perforators. And I'm just dissecting. I don't coagulate in that part without seeing anything. And you will see now the perforator, M1 perforator, lateral lenticular striate in the base of the aneurysm. Small aneurysm can be more difficult sometimes, as all you know. And I couldn't separate. I used cottonoid to separate, and the other side to separate, and then it is totally adherent to insula and M2. Again, I take out the temporary clip again, and I put again. And now I'm almost going to see the perforator. You see, these are the perforators. So we have to be careful when coagulating around the perforators. So the neck is now almost ready for clipping. So you see the perforator here, and I try to put a clip. And use the suction also, but it doesn't look good to me. So I play a little more, and I see more, and then I change the clip. And look again, and coagulate. And I put at this clip now. The clip should not be very short, should not be very long, of course. I'm not happy. This is, you see the perforators now clearly. And I take out and I perform ICG, but you see there is something else here. You know, there is some, you can see the whole perforators intact. And then this is also sick. So I cannot put one clip, so I put a separate clip for that part. So I think the bipolar was help to me for this case. So I have last case. I have to stop other cases because that's I lost my time. But this is my last case.
Another minute, Ugur.
What?
You've got 1 minute.
Okay. So this is my last case. This is the case that 2 months ago, history of progressive right-sided hypoesthesia, hoarseness, gaze disturbance, and swallowing difficulty. This is typical medulla oblongata cavernoma with blood and the cavernoma itself. And it's very nice case to operate through the midline because it's almost on the surface. So this is nice medulla oblongata cavernoma. But if you pay attention to this angiography, this is thrombosed, totally thrombosed, pica aneurysm, and it bled within the medulla oblongata. And if you go this way to this case, it can be a disaster, of course. In pica surgery, I mostly prefer midline approach because if I come lateral, aneurysm is in other side. So in the left side, I go midline and I control both vertebral, and then also I can get the base of the aneurysm that I would like to just show you. I perform it in prone position, and then left vertebral is clear and right vertebral is in front of me. So I prefer midline approach mostly in pica, and then this is left pica. The left vertebral, I am getting the aneurysm, and I put a temporary clip to left vertebral, and then I start to dissect. If something happens, I can put another clip to right vertebral, and I can see the aneurysm that it goes inside of the medulla oblongata. Interesting. This is not subarachnoid hemorrhage, intramedulla oblongata hemorrhage. And I perform ICG, and then I put a temporary clip to distal part, and then I get the base of the aneurysm. This is spica, and you see I am happy that I came from midline, because if I come from lateral, the aneurysm, it will be in the other side. So I separate it from the medulla oblongata, and then I put a clip. And I felt happy, but remove the temporary clips. But pica is not working. And then I put another, again, temporary clip, and I coagulate the base of the aneurysm and separate from the medulla oblongata more. But it was totally attached to the medulla oblongata. When I move it, the brain stem was coming to me also. And then, but I had enough space to put a new clip. Again, I am happy that I went through the midline, because I can get the base of the aneurysm with this approach. And then the ICG shows and the system is working. And interesting, just what I operated 1 month ago, you see the aneurysm here. I didn't remove the aneurysm from, because it was totally adherent to the medulla oblongata. But 1 month later, this is the CT scan of the patient, the aneurysm is almost collapsed. This is also interesting. Sorry. So bipolar coagulation is useful in shrinking and shaping and amorphous bulging areas of some aneurysms, not all aneurysms. Of course, it's dangerous to use it, especially around the perforator. So we have to separate perforators, and then we can use it. and I'm happy to work with my team, and Professor Yaşargil is with us. And after COVID, we look forward to see all of you in our department, especially next June, not 2021, 2022, because of COVID. I look forward to see you in our meeting, Future of Microneurosurgery and Semi-Sitting Position. Thank you for your attention. I am sorry for video problem. Sorry.